Support for Carolina Business Review provided by Grant Thornton. Operating in more than 100 countries, our tax, audit, and advisory professionals specialize in helping companies unlock their growth potential. Blue Cross and Blue Shield of South Carolina, where healthcare is changing for the better. Find out how at ahealthysc.tv. And by Sunoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services, with more than 300 operations in 35 countries.
Welcome to part 2 of Mental Health in the Carolinas. Last week we talked about our current status, where we came from, what is going on now. This week we will take a forward look on where we're headed, especially given the long shadow of the Affordable Care Act. Please stay with us.
Major funding also by Novant Health, bringing you world-class technology, clinicians, and care when and where you need it. The Duke Endowment, a private foundation enriching communities in the Carolinas through higher education, healthcare, rural churches, and children's services. And by Blue Cross and Blue Shield of North Carolina. Who's responsible for rising healthcare costs? Join us and many others in a candid discussion at letstalkcost.com. On this week's program, Sheriff Chipp Bailey of Mecklenburg County, Deby Dihoff of the National Alliance on Mental Illness, Dr. Peter Liggett from the South Carolina Department of Health and Human Services, Dr. Janice Probst from the South Carolina Rural Health Research Center, and Mebane Rash of the North Carolina Center for Public Policy Research.
Hello, welcome again to part 2 of Mental Health in the Carolinas. Folks, welcome back. Glad to have you here. And really, thanks for staying, is what it came down to. Last week we kind of ended near how Affordable Care Act plays into all of the mental health thing. Mebane, I want to start with you. It seems that mental health would need a champion. I mean, and when I'm talking about a champion, I mean someone in the General Assembly or the State House that is going to carry the banner to say, you know, mental health is important and this is the reason why. Do we have any champions for mental health?
Well, it may surprise people that I'm going to say this, but it may be Pat McCrory. I mean, from the beginning of his administration, he has said that substance abuse and mental health would be a top priority for him. He came in and we were a little bit worried because he came out of the gates and proposed something called comprehensive care entities, which would have replaced our local management entity, managed care organizations. But Dr. Aldona Vaush, who's the Secretary of Health and Human Services, paused. They set up a Medicaid reform advisory group. They listened to people across the state. Anybody could submit comments on the website. And as Dr. Vaush said, they listened and they listened and they listened. And they're rolling out a compromise plan that does not get rid of the LME MCOs and keeps them. It does consolidate them. But it may turn out to be that this administration is going to be a champion for bringing some stability to the system.
Yeah, I have to ask you the same thing, Pete. Does South Carolina have a champion? And maybe in the State House, maybe not. But don't they need someone high profile, screaming from the mountaintop, saying that this is a challenge?
Well, I would certainly say that our governor, Nikki Haley, has been a champion for mental health. She's introduced new funding for telepsychiatry, for school-based funding. Also, our director, Tony Keck, has made mental health one of his big priorities. The position that I'm in, Deputy Director for Behavioral Health and Long-Term Care, is a new position because he saw that mental health needed to be elevated to a deputy level. Our advocacy groups, though, are just amazing in the work they do. Our Bill Lindsay with our NAMI chapter, Joy J with Mental Health America, wonderful, wonderful folks. And we have an amazing Department of Mental Health system. We have one of the few, if only, state-owned mental health systems that includes community mental health in South Carolina. It's one of the oldest as well. And John McGill, our director, is certainly a strong voice for an advocate for the mentally ill.
So how, Jan, and Debbie, I'm going to ask you this question too. How does the Affordable Care Act compound or put the wind at the back for mental health? How does it change it up?
I think it will help, although the jury is clearly still out. What the Affordable Care Act does that was not present before is say that all insurers must offer mental health services. They can't say, well, I'm going to cover this, I'll cover you if you get hurt in an accident. but they can't say, I won't cover you because you're depressed, or I won't cover your child because they have started to manifest schizophrenia. I think just that could be huge, because all the financial burden of care, as we know, is outrageous for mental illnesses, outrageous for all illnesses. If you go to an emergency department, prepare to be surprised. I think the fact that insurance covers it does two things. It takes away the financial burden, and it says to people, well, this must be okay. Look, they're going to pay for it. It's not something illegitimate that they wouldn't pay for before because it was of lesser value. So I think you've got the chance of, for those people who are affected by the Affordable Care Act, which in our 2 states is going to be the people who are privately insured, that you're going to have an increase in support financially and it's sort of an increase in support emotionally.
So the Mental Health Parity and Equity Act also recognized that just covering those mental illnesses is not enough. Bringing the service level up to something that is similar to primary health care was also a part of that. So it's not okay to say, yeah, we'll cover depression, but we're only going to give you this much service, but we're going to give you this much service on the primary health care side.
So how, and I know you don't speak for the state officially, but how, here, compound this fact, on top of the ACA, and North Carolina says no to Medicaid dollars, how does that make it harder or easier? Or
Well, that's a very controversial question you're wanting me to comment on. Of course, we're disappointed in North Carolina not to extend and expand Medicaid to cover more people, because people need health insurance. That's a key to their getting the treatment that they need. But one thing I wanted to go back to that Mebane brought up about Governor McCrory is, and I think this may happen as a result of the Affordable Care Act, even for those states that have not done expansion, it's the need to really integrate physical care, primary health care, and behavioral health care. And I think the whole medical home concept will help bring that about. And I would give a lot of kudos to our administration, because they're really concentrating on how to bring those together. And it really kind of is rocket science, because the billing systems, the financial streams, it's going to be a difficult change. But we have some really we have excellence in North Carolina in both of these arenas. The trick will be to tie them together. And it's so important, because people living with mental illness came out in the comorbidity report back in, I think it was 2007. They died 25 years before people who do not have mental illness. So right there, parity, the affordable insurance, making sure that you care for the whole person becomes huge. And we're beginning to start that journey in North Carolina.
I know you're an academic. You don't need to raise your hand in this conversation. Jump in.
Force of habit. I want to pick up, that is such a wonderful point about integrated care. And I actually, there are innovative things going here in in North Carolina, where people are through the community health centers are offering truly integrated behavioral care, where you go to one place and here's your primary care doctor, and if the primary care doctor senses that you might be having some issues, he says, well, Mrs. Smith, I'd like you to talk to Dr. Brown in our office. And it's not like Dr. Brown is some weird person set aside.
Right.
It's just integrated right into the flow
Weren't
of all the
primary
care
care
the person
docs
gets.
doing that anyway, though? Wasn't kind of their role?
Some of them are. I used to teach in a family medicine department, and behavioral medicine training is part of the training that family physicians get, but it's only 2 months out of 36. This is not the level of a professional. They can't deal with all of it in detail.
Sheriff, you're back there nodding to some of this. How do you reflect on Medicaid? How's that going to impact what you're trying to do?
Well, if, virtually everybody in my custody would
fall
for the
into
most
that
part,
demo.
would fall into that category, and that would certainly help offset the cost. We do bill against insurance when they have insurance, and so the more who are eligible under Affordable Care Act or Medicaid would certainly benefit us in that we could bill against that and not be absorbing a lot of the cost that is taxpayer money.
Mebane, both states have turned away Medicaid, at least have indicated that they want to turn away Medicaid, and they are. How long can they say no? Do you think there will be a groundswell?
I think we'll have to wait and see how it plays out and what happens with that pocket of the population, and do they find other ways to access insurance, how the penalties of the ACA play into that decision for them. I think we also are watching other states that are finding other ways to get people access to insurance other than using Medicaid dollars as the lever.
So the question, though, is how do we get them access to health and health care? And in South Carolina, we have a new initiative called the Healthy Outcomes Program, and we've identified 8,500 high users of emergency rooms. And that's where we see the enormity of this problem typically is in our emergency departments. Our Healthy Outcomes Program has gotten all 65 of our acute care hospitals into 46 partnerships between emergency departments and our federally qualified health care centers, our rural health centers, free clinics, community mental health, and alcohol and drug abuse providers. We're taking money that typically gets used for indigent care for people who don't have insurance. We're taking some of that money along with some state dollars and funding these partnerships. Essentially what we're doing is we're using the triple aim, which is per capita costs going down, a better consumer experience, but also population health. And so if you look at that 8,500 population, we're targeting that group, and we're finding that about 70% of them have a mental health issue. We're able to get to those folks in a targeted fashion rather than sort of giving everybody a Medicaid card and assuming that that's going to get them into health care.
You know, all right, well, let me stay with you, Pete, here. Then there's got to be, I mean, we're talking about collaborations, and partnerships and all that. I would guess, have you talked to, many businesses have employee assistance programs, EAPs. We've all heard of them, maybe even used them. There seems to be that there's a connectivity between business reducing their costs for health care, whether it's mental or otherwise, and helping the state reduce their effectiveness or increase their effectiveness. Is there a role here? Are we missing something that's obvious that we could be doing better?
I mean, absolutely. I think that the role of the partnership between private sector business and our public health policy is critical. In South Carolina, almost a quarter of our population is a Medicaid recipient, and over half of our kids are Medicaid recipients. And so, in terms of the interaction between our business community and our population, there certainly is some crossover between those folks that are receiving those services and our businesses. And we know that mental health issues really do impact productivity and a person's ability to be employed. And so we want to see people in recovery through supported employment, supported housing, and other types of services so they can be gainfully employed.
Go ahead, Mebane.
I'll give you a different example of just an obvious thing that we're missing. And we think of people needing insurance to have access. But often it's just basic communication that impedes access. So when you look at North Carolina's system, there's nothing about local management entity or managed care organization or LME-MCO or even the name of the place itself. So for instance, in Mecklenburg County, MecLink, that screams, this is where you go to get mental health services. People don't know who to call.
Why?
It's not intuitive.
Is it that fragmented?
And if we can't navigate it ourselves, think about somebody in crisis.
Yeah, in the old days, there used to be a community mental health center. Everybody in the community knew where it was. It was a building. It was kind of big. DSS knew where it was. Families, police knew where it was. All that has changed since we've privatized mental health, and it's not readily visible. And I think we need to give attention to those symbols. How do we reinvent a place to go to? How do we make sure that the police know where to take somebody who has been identified with mental illness? Because many times they don't know the options that exist in their community, which might include mobile crisis teams, crisis facilities, and there's really a lack of spelling things out for people, making it easy to find.
It would seem that the faith community has a role to play here. Can churches be a resource? Are churches a resource? Does anyone have an example of a church being, a front door, a gateway, so to speak?
I think one of the programs within most churches, the Room in the Inn program that brings in homeless and works with the homeless. Granted, they're not treating them, but a high percentage of the homeless do have some form of mental illness.
More than half, Sheriff?
I don't know a number, but I would guess that would be the case.
Mebane, do you
the
know
experts
that
are here.
I don't know that number.
But they're providing them clothing. They're giving them a good place to sleep at night for one night a week, and several churches do it in concert with each other. So I think that type of effort is ongoing in a lot of churches. I don't know about programs designated just to deal with folks with mental illness, but certainly they're encompassing that through some of these others.
Yeah. NAMI has some programs working with churches, basically many people who live with mental illness, of course, go to their primary care doctor instead of a specialty person, or they go to their clergy, they go to their ministers. So what we try to do is train churches to be accepting of people with mental illness, to be welcoming. And it's not always somebody who's homeless. It can be somebody who has a brother who has bipolar disorder, who has a job, but they still need support. They still need to get a casserole when their loved one is in the hospital. And churches need to feel comfortable doing that for people with mental illness, just as they do when somebody has cancer.
And that's a really important point, Chris. 1.4 million people in North Carolina, the state estimates, have mental illness, developmental disabilities, or substance abuse. That's about 14% of our state's population. So this is an issue that touches all of our lives. Rich and poor, all ages, all races, Democrats, Republicans. That's part of getting past the stigma and designating it as a problem. This is just part of our life.
It seems to be designated when it become a problem when there is a high-profile event like Sandy Hook. And you know, I'm very careful about patronizing those very tragic Aurora, Sandy Hook, Columbine, Virginia Tech, and the list goes on. Too many, to be quite frank. So, when it comes to those type of events, how do we really further this debate around the mentally ill with gun permits? How do we handle this? What is the appropriate? Sheriff, I got to start with you. I mean,
Well,
I know you probably don't want to.
Well, we do, obviously when we issue gun permits, we have to follow state law. And, but we do go a little bit beyond in that we check our own logs for involuntary commitment and those types of things so that we don't issue one to somebody who's recently been involuntarily committed.
I'm sorry, Sheriff, you're referring to the debate around those with involuntary commitment, and that's an important point.
Right.
Not being issued permits or being revoked. The
Now,
privilege.
there's a new law that came out last year that if somebody has committed a crime or visits a hospital that for treatment of mental ill or substance abuse, those types of things, we're supposed to go back and revoke that purchase permit. Well, I don't know how that's going to work because it's still in the early stages, but a lot of people have already used that purchase permit to purchase a handgun. They don't have to have a purchase permit to go and get a rifle and those types of things. So if that's not showing up, it's still up in the air as to how all that's going to work. But it's certainly a concern as the agency designated with issuing concealed carry permits and issuing purchase permits that we don't issue it to somebody that has an obvious issue with mental illness. It's a little bit of a slippery area to walk.
Go ahead, please.
I'm obsessively raising my hand again. We actually talked about this in the room before we came in, and I think there are two problems with tying the mentally ill as a population to some sort of really heart-wrenching event. There's the problem of you cannot always predict these, so that saying we won't give you a gun permit after you've been involuntarily committed is the classic closing the barn door after the horse is gone.
Right.
The second problem is that it detracts a lot from the vast population of persons who are mentally ill, who are overwhelmingly the majority of whom are going to be withdrawn as a consequence of their disease, rather than doing something overt like this. Most crimes with a gun are going to be committed by someone who is mentally sound, but is in a moment of anger or uncontrolled rage. That's not going to be addressed by this problem. And like I say, it really does a disservice to the vast population of mentally ill persons who are going about their business every day and who do not deserve to be stigmatized as mad shooters who might turn on you at any moment.
You know, most people with mental illness are victims of crime, actually.
Correct.
Statistics absolutely supports that. And when Americans have been polled on this issue, they come together around one thing, which is we need to do a better job of prevention and early intervention treatment. It comes back to what Pete said about school-based care.
Hold on the issue of what, Debbie? Of this
On
involuntary
how,
commitment and
Sandy
the carrying of
Hook,
guns?
how people are feeling about guns, and what should we do to move ahead?
Okay.
Given a choice, do this or increase treatment. Everybody agrees that we need to work on treatment and prevention. And why not start in the schools to make it easier and less stigmatizing for kids who may have transport issues and trying to access care that we've talked about? Get some more school social workers going in the school system and start early, intervene early, work on ways for communities to be supportive and wrap around those families who, in all the cases that you mentioned, they were known to the community. And we have huge problems with getting programs post-high school. People drop off a cliff and there's not much going on.
Once
and
they turn 18, they're on their own.
and we need to look at churches, family supports, community supports, destigmatizing, helping be more accepting of people living with
We're getting
mental
back again to the access and capacity problem that we have both in North and South Carolina, where both states have less than average numbers of psychiatrists, psychologists, social workers, and counselors. And so I think going forward, we need to address a workforce development concern that we have.
Thank you. Good point. That was going to be a question around workforce development.
I don't know about in North Carolina. In South Carolina, we've put a lot of money, over $200 million, into graduate medical education to get physicians in the state, and certainly psychiatry is a focus of that. But we've also got to focus on graduate education for those other allied professionals like psychologists, social workers, and counselors. And we either do that through a loan repayment program where they give back service, or some kind of tuition assistance. But we've got to get more people on the ground that can treat these individuals and provide services.
We have about 3 minutes left, and I want to not be Pollyannish about it, but I want to end on a good note here. Mebane, what are you most encouraged about around the mental health issue in North Carolina?
So I'm most encouraged about the direction that we see our administration taking. So they decided not to move forward with the CCEs. We're going to retain our current structure. We're going to consolidate from 10 to about 4 LME MCOs, that's local management entity, managed care organization. But that'll give that system some time to grow. They're making some changes in response to their first year that seem prudent to me. They're going to make some contractual changes. There's also going to be more oversight and technical support from DHHS. I think one of the most exciting things that we've already alluded to is there is an intention of this administration to integrate behavioral and physical health care. We're not sure how we're going to do that, but that's a step in the right direction.
Sheriff, you've been on the anecdotal, you've seen the anecdotal evidence, you've seen statistical evidence. What are you encouraged about around mental health?
Well, I'm encouraged about the programs that are like CIT training, the crisis intervention training that is available now to police officers, to our detention staff, and also to the prison correctional staff. I think that gives us a tool that we can use to be successful in dealing with individuals and recognize the issues and problems. And that didn't always exist in law enforcement, and a lot of police officers got hurt, a lot of citizens got hurt because they just didn't know how to deal with individuals who might be having some problems. And so that kind of availability and training I encourage all police agencies to take that on, all sheriff's offices to take that on. It's important.
Professor, what are you encouraged about?
What am I most encouraged about? I do think that we have an opportunity going forward to level the playing field. And I think if, like I say, that notion, if it's equally funded, it's equally valuable, I think maybe we will get more of attention to mental health illnesses with less of a feeling that it is a moral defect rather than a true illness.
Equally funded versus?
Under the parity laws, whereas previously you didn't have to do mental health because it wasn't real. If it is real, then we're saying it is a disease. It's not something that you did because you were purposely being evil.
What are you most excited about?
I'm excited about us moving toward a coordinated system of care in our state, and I know other states are doing this, bringing agencies that have typically been fragmented and play hot potato with kids and families, coming together and coordinating their care so that kids are getting consolidated treatment from prevention all the way up to the very deep end kinds of care. And I'm also excited about us looking at housing. Housing is one of the critical elements for the serious and persistently mentally ill vulnerable adult population. And without good housing, recovery is very, very challenging.
Yeah, that's going to be the last word. Pete, thank you. Debbie, sorry, we didn't get you on that one, but next time we'll continue. I know the dialogue's not over.
I had 2 great ones for you, Chris.
You had 2 good ones? Tell me off camera.
Okay.
Thank you all for being here. Nice to see you. Thank you for watching. We hope you got something out of it. If you didn't, and or you do have a comment, carolinabusinessreview.org. Next week, I'm Chris William. Good night.
Major funding for Carolina Business Review was provided by the Duke Endowment, a private foundation enriching communities in the Carolinas through higher education, healthcare, rural churches, and children's services. Blue Cross and Blue Shield of North Carolina. Who's responsible for rising healthcare costs? Join us and many others in a candid discussion at letstalkcost.com. Grant Thornton. Operating in more than 100 countries, our tax, audit, and advisory professionals specialize in helping companies unlock their growth potential. Novant Health, bringing you world-class technology, clinicians, and care, when and where you need it. Sunoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services, with more than 300 operations in 35 countries. Blue Cross and Blue Shield of South Carolina, where healthcare is changing for the better. Find out how at ahealthysc.tv. And by viewers like you. Thank you. Promotional consideration provided by Business North Carolina Magazine. For more information, visit carolinabusinessreview.com.